So I actually got exposed to cardiology when I was in college. For a summer job, I took a per diem job as an EKG tech. So I got exposed to stress tests, EKGs, caths, everything that folks were doing in one of the local hospitals. All of that said, when I ended up in medical school, I thought I was going to go into emergency medicine. But when I was going through my emergency medicine rotations, I started to realize, again, the things I was really drawn to were all cardiology based. I really liked the physiology that was related to cardiology. I liked the intensity of what patients would come in with heart attacks. And so lo and behold, I ended up deviating a bit from the emergency medicine and went into internal medicine, knowing that I was going to eventually go to cardiology. I didn't necessarily know I was going to go into interventional cardiology actually until my cardiology fellowship. I started rotating through the catheterization lab and was really drawn to the teamwork experience that was there, as well as all of the neat devices that we have and the ability to really take a patient who, was having, a heart attack and a lot of discomfort and really be able to do something that could turn things around for them and help them. I was really lucky that I had some wonderful attendings that I worked with who, even though there aren't a lot of women in interventional cardiology, really were incredibly encouraging for me and helped pave the way. And well, there you go. That's where we are. So in addition to being a practicing interventional cardiologist, I also do a fair amount of research, and my research interest is particularly in the area of health economics and looking at cost effectiveness for new cardiac devices that are coming onto the market. So I think what I'd say my biggest achievement is I was able to lead a couple of economic sub-studies that have been embedded into large national trials evaluating cardiac devices. Most recently, I presented at TCT in 2019 as a late breaking clinical trial looking at the cost effectiveness of the MitraClip in patients who were treated either with medicines or with the MitraClip who had secondary mitral regurgitation. So I've definitely continued to be busy from a research perspective. I'm continuing to work on a couple of health economic studies that are coming out. One is for the Protected TAVR trial, which is looking at the use of the Sentinel device, a cerebral embolic protection device in patients receiving TAVR. I'm also involved in looking at the economics associated with the STEMI DTU trial, which is a trial that's evaluating the concept of LV unloading with the Impella device versus standard of care in patients presenting with anterior STEMI. Certainly the results of these trials are a few years down the road, but it's exciting to be part of them. And I certainly think that the costs of these devices, particularly in our healthcare environment, are going to be incredibly important in understanding what value these treatment strategies bring, not only to the patient, but also to the healthcare system in general, is going to be of immense importance. Well, I think one of the most exciting, and again, I'll preface this by saying I'm probably a little biased, but I think one of the most exciting things that's happening is really happening in the structural world. We know that TAVR completely transformed how we treat aortic valve disease. And there's plenty of things going on from a mitral valve space as well. But we're just starting to get into the tricuspid space. And this has really been the forgotten valve, the forgotten treatment area that we just really don't know how to manage. But there are so many new devices that are in the pipeline that are being investigated to treat patients who have severe tricuspid regurgitation. These trials are just getting off the ground, and we're figuring out how do we study these patients? How do we study these devices? And so I think it's a really exciting time to be part of the structural research community. So I think one of the things that we've been talking about a lot in the last year in particular has been the underrepresentation of either people of color or women, both not only as patients in clinical trials as well as in clinical trial leadership. I've been really excited to see that there's been more interest and more attention being brought to these issues, because I think that we'll be able to, by including people both as clinical leaders as well as patients, we'll really be able to improve some of the disparities of care that have been highlighted, particularly during the COVID pandemic.